super good. Hello, everybody, and welcome to the PT on Ice Daily Show. My name is Christina Previtt. I'm one of two lead faculty for Modern Management of the Older Adult, the Modern Management of the Older Adult curriculum. We are a 3-course series. We have our online Essential Foundations, Advanced Concepts, and our live course. And if you are completing all 3, then you can test for CERT MMOA. We have a very big announcement coming in the MMOA world a week and a half from now, so 10 days from now, in the next version or edition of MMOA Digest. MMOA Digest is a bi-weekly email that puts together things that we've seen in the research sphere in the world of geriatrics. So if you guys are not on that email list, our big announcement is going live on that email in 10 days, and we are super, super excited. All right, live courses coming up. I will be at Sampler, literally my first time traveling in over a year because I've been up here in Canada. Crazy. So I'll be at Sampler March 27th talking about some of this around hip replacements and osteoporosis hip fracture. Then the 17th, I'm in Victor, New York. And then the 24th, 25th, I'm going to be in Charlotte, North Carolina at Onward Charlotte, teaching Modern Management of the Older Adult live. I am so excited. So I hope to see you all there. Okay, if you all get Hump Day Hustling, you saw that there was a very interesting article that was published in JAMA, the Journal of the American Medical Association, that was talking about whether or not PT is needed after a hip replacement. And so I always think it's kind of funny, and I'm going to talk about this preamble first, is that I feel like most of us as clinicians think that arthritis is a pathology like, we got this. Like, we know what we have to do with arthritis. We know what to expect. But it's funny because with the curriculum, we talk about arthritis specifically, so I'm constantly kind of dipping into the literature, and it's changing. So it's just fascinating to be able to follow the literature and just see that, you know, arthritis, which we talk about as wear and tear in the joint, especially osteoarthritis, we think that there's nothing that's really going to change in the world of arthritis, and that's just simply not true. 5 or 10 years ago, we always just assumed that osteoarthritis, for example, was a biomechanical condition, but now we know that there's an underlying low-grade inflammation that's a part of the pathology, which means that inflammatory rising in processed sugar and that inflammatory cytokine that's being released by excess adipose tissue is also going to be contributing to the pathology. Super interesting. So where are we going to take this today? We're going to talk about joint replacements. And I've talked previously about an old systematic review that looked at the anterolateral approach to hip replacement and the use of hip precautions. Since then, 2 other bigger systematic reviews have come out talking about precautions. And then from there, I want to tackle a little bit about what that article means around rehab and what can we do as PTs. So number 1, to remind you, there was a systematic review in 2015 that showed that there was no decreased risk of hip dislocation post joint replacement, hip joint replacement, using an anterolateral approach for individuals who were given hip precautions versus those that were told to gradually move into range of motions they felt comfortable with. That had low quality evidence. There wasn't a huge randomized control trial, and it was the first idea that we may actually be negatively impacting a person's quality of life, and we may be creating more fear of movement than necessary that actually is going to take away from the reconditioning process post joint replacement. Super interesting, but we still had a lot more work to do. In 2018, there was more updates to the literature that included not just the interlateral approach, but also lateral and posterior approaches to the joint replacement. And again, showed no increased risk of dislocation for those being told to move conservatively and gradually move into range of motion versus those that did not and had those hip precautions in place. In 2020, There was a third systematic review that incorporated much more individuals. Now we're getting close to 1,000 participants, and compared the amount of individuals who had a hip dislocation post joint replacement with a posterior approach versus being told to cautiously and gradually move into different movement patterns. I'm guessing you're going to understand what I'm going to say is that it again showed no increased risk of dislocation with the posterior approach. And so one of the things that was criticized in the 2015 article, not criticized, but saying we still need to ask these questions, is that we know in general that the anterolateral approach is going to have a reduced risk of dislocation in general versus different posterior approaches. And that's because we're saving more of the muscle bulk and we're moving around muscle bellies versus transecting through them in the surgical approach. Therefore, the stability around the joint gets maintained and reestablished much earlier in an anterolateral approach than a posterior approach. But this systematic review said also with a posterior approach, we probably should not be advocating for hip precautions because it can reduce an individual's movement post hip replacement. And we want to make sure that we are encouraging reestablishing strength and stability around a hip that has just been replaced. This kind of comes in to that article that was being talked about in the Hump Day Hustling. What they showed was that rehab may not be as effective or maybe equally as effective as individuals who are told to just move after a hip replacement. If you are in the Jerry PT world, you know that in general, many individuals after hip replacement do exceedingly well when it comes to their rehab, as long as there isn't any postoperative infection or dislocation that's leading to a revision. What that means is we may have to start reconceptualizing what we think PT is in a post-joint replacement world. When I first moved to Kingston, Ontario, I met up with the physical therapist that was doing all the advanced care roles where they were actually being the ones who were seeing individuals before they were put on the list for joint replacement. In Canada, we have that list going because we're public health care. And so they would do their subjective and objective reporting, talk to the surgeon, and together they would make the recommendation to place them on a list for joint replacement or not. Why is this important? When I was talking to them about who is the provider that generally gets the referral after joint replacement, their response was they would rather their clients just go to the gym. This kind of goes in line with what JAMA has said in their article around, we just need to be encouraging movement. In ICE, we talk about being fitness forward, and maybe we need to start reconceptualizing what we are thinking traditionally as rehab for a joint replacement, where we need to be taking an individual's day. In Canada, we have a prescribed care pathway that is generally low-dosed exercise with some manual therapy thrown in to reestablish a range of motion, especially at the knee, and gradually go into these ranges. But if we're starting to ditch hip precautions, and that's one of our role was traditionally to help individuals navigate different things in their activities of daily living in order to stay in line with what those hip or knee precautions were. And then it was to gradually increase range of motion into those precautions once lifted, when hopefully they were lifted by the surgeon. Sometimes that's not the case, and that's a whole other rant. And then third is to gradually reestablish strength. And so my response to some of those articles is that number one, our typical Jerry PT criticism is that we are traditionally seeing underdosed exercise, and this includes in the joint replacement space. So I would like to see what the actual exercise protocols were. And number two, what I'm starting to see is that we are using manual therapy and psychologically informed practice in order to drive down that pain pathway so that we can build them up back up and load them appropriately. And if you've been following any of the faculty for any amount of time, you know that we try to transition into heavier loading, which is relative in a geriatric space, particularly as quickly as we can. And so our role potentially may not be that we're doing this specific course of care post hip replacement. We might actually be more of a coach where we're maybe doing a more consultation-based model where we're looking at exercise programs, and we're starting to ditch all these things and DC things that are too easy and start pushing the paradigm and have more and more people who are starting to use this type of modeling to allow our clients to get as strong as possible and have a check-in to remove the fear of movement. My job most of the time, especially after hip replacement, is to start reestablishing strength and to extinguish fear of movement that has been created because they've had a major surgery. So if we can allow our clients to utilize us as a goalpost around navigating the terrain of returning to whatever it is that they want to return to post hip replacement, we could probably really optimize our outcomes, and we could see really great increases in strength, improvements in quality of life, and improvements in satisfaction with joint replacement. But what we know is that some of these restrictive precautions can actually do the exact opposite. They can start to instill fear, and they can start to decrease satisfaction with the surgery because they think that they're going to get out of pain and that they can move freely, and then they get slapped with restrictions that make it extremely difficult for them to navigate different day-to-day tasks. And sometimes these restrictions are on for 6 weeks, sometimes they're on for 3 months, sometimes they never get told when they stop doing it, and then that fear and sensitization begins and stays for even longer than necessary. When we flip to knee replacements, we know that reestablishing range of motion is such an important part of care when it comes to post-joint replacement rehab. And our literature is a little bit stronger in terms of the need for at least manual therapy in the acute setting and different exercise protocols to help really push the knee into that amount of flexion to get at least hopefully in that 100 and 110 degrees of knee flexion post-knee replacement. One of the things that is often, there's not as many precautions necessarily around knee replacements. Oh my gosh, I've been ranting for 16 minutes. Okay, I'm gonna make this quick. Precautions for knee replacement, there isn't necessarily as many, but what we are starting to see is that it's the kneeling piece of it. When we think about older adults after knee replacement, many are told that they can no longer kneel ever. Number one, this is simply not true. I don't know where that came from. Most of my clients wouldn't voluntarily be kneeling in the first 6 weeks post-replacement. It's probably not what they would be doing. But eventually they need to be able to get up off the floor. They need to be able to do the things that they want to do, including things like garden, and telling them that they are going to somehow dislodge their prosthesis, which is often what happens in their mind. Like that's what they've been told. There is a huge amount of fear that comes in when we think about kneeling and trying to recover off the floor. And so sometimes when I'm working with a client post-knee replacement, whether it's in the acute setting or further along in their rehab, and I start talking about floor transfers, they say, no. I was told I'm not allowed to kneel on my joint ever. It's going to wear it out or something is going to happen. And what that does is it creates a fear of falling. It restricts their freedom of movement. Sometimes it makes them avoid tasks that they really enjoyed, like gardening, because they can't kneel anymore. And so it makes it extremely difficult for them to complete some of their gardening tasks. And again, we're getting into this pattern where instead of being helpful, we're being harmful. And we talked about when helping hurts a lot in the Jerry PT segments. And this is another example where we do not have any evidence to support that kneeling is going to deteriorate a knee replacement faster. We just don't have that research to support it. I've done PTNA segments where I have talked about the fact that I want to wear out your joint. That means that you are active and healthy and engaging in different planes of movement and strength training and lifting your grandkids up off the ground. I would rather have a healthy person with a joint replacement that has to get revised 12 years after it was done because they have lived their life versus having a person who maintains their joint for 15 years and goes into that negative feedback loop of deconditioning, chronic disease, and increased inflammation and have that go over and over and over again. So when it comes down to it, I think we're going to start to see a shift in rehab. we're going to start seeing that hip precautions are not going to be used as much. And I know that it is a hard conversation, and everybody says to me, but my surgeons keep saying, and I totally agree. Sometimes if you have a good relationship with them, sending them this literature and saying, what do you think about this, is going to be helpful, and do it in a mutual learning type of environment. Or make sure that you're the one who says, you are far enough after your replacement. You can now not be afraid, and let's go through some of these movements together so that you know that it is okay for you to move in these planes and for you to do these things, and let's get you as strong as I can possibly get you. All right, that is my ramble for today. I hope you guys found that helpful. It is very interesting in the arthritis research. We think that there isn't anything happening in this world, but it's definitely changing. And we need to make sure we're staying on top of this, because sometimes like that JAMA article could easily be what would trigger a loss of funding for certain parts of PT care. So we need to make sure that we're watching out for some of these articles and making sure that we can respond appropriately to them. And that is just what is part of the reason for, staying at the top of our license. All right, I hope you guys found that helpful. Look out for MMOA Digest next Friday for that big announcement. I hope I see some of you at the sampler, and have an awesome, awesome end to your Wednesday. I guess the start of your Wednesday. Bye.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.